My name is Dr. Daniel Kiernan. I'm a retina specialist with Ophthalmic Consultants of Long Island, and I've been in practice for about 7 years. Diabetic macular edema is a major problem within my patient population. I'd say a good 30% of my patients have it, and I treat them on an ongoing, regular basis with frequent injections, laser, sometimes even surgery. Many patients could benefit from more continuous therapy, but simply because of medical problems and life in general, they just can't come in as frequently as I'd want. Therefore, I think a continuous therapy is a great option for many of these patients. My DME treatment strategy typically starts with an anti-VEGF injection. I'll try that for a few months, and if I see the fluid go away, well, that's great. Many times we can then supplement with either focal laser if necessary, or just watch the patient and treat as needed. However, as many times is the case, that the diabetic macular edema is more severe and there's fluctuation of the fluid in the vision, I will consider a corticosteroid treatment. And after that, if I see no clinical significant rise in intraocular pressure, I will then use a continuous microdose therapy such as ILUVIEN. Persistent DME is fluid that persists on exam or OCT testing in spite of multiple prior treatments for diabetic macular edema, such as monthly anti-VEGF injections, or recommended prior treatments that don't happen because of missed appointments or other reasons. In these cases, I think these patients would benefit from a continuous microdose therapy such as ILUVIEN because it continues to release fluocinolone acetonide over up to a 3-year period, which allows a therapy for the patient even if they're missing their appointment due to hospitalizations, dialysis, or if there's a snowstorm and weather prevents them from coming in. These are the type of patients that are very common among my DME population that would certainly benefit from ILUVIEN.
I'm an avid reader, that would be cut out. I'm an avid fisherman, that might be cut out. Certainly can't drive anywhere. The ability to take care of myself on a regular basis, to go up and down stairs, to do laundry, to cook a meal, would be not only greatly diminished, probably eliminated. So that is a lifestyle change that I don't think anyone, can grasp. It's just a horrible idea, and I would do anything I could to avoid it. The difference that ILUVIEN has made in my life is that it's been 1.5 years since I've had to have an injection. I'm glad the ILUVIEN is given to me.
When I'm speaking to patients about the potential side effects of ILUVIEN, one thing that comes up is the possibility that corticosteroids, including ILUVIEN, can cause worsening of cataract. However, at the end of the day, I do want to preserve the patient's retina and reduce the macular edema because that's more likely to cause permanent vision loss. I explained to the patient, diabetes can cause worsening of the cataract, as can the corticosteroid. But really, we want to make sure we dry out your retina and we preserve your vision, because you can always have cataract surgery, but if your retina is destroyed from the diabetic macular edema, there's no going back. I really don't have concerns about intraocular pressure spikes when I treat patients with ILUVIEN because it does require a prior course of corticosteroids showing that there is no clinically significant rise in intraocular pressure. Furthermore, in a few cases where I have seen the pressures go up, I've been able to easily manage them with topical intraocular pressure lowering drops. I would advise a patient to receive an ILUVIEN if I saw that their diabetic macular edema was persistent, or if I saw that they weren't able to come in for a monthly injection, I would recommend a continuous microdose therapy such as ILUVIEN. I'd recommend ILUVIEN to all my retina colleagues because it provides a continuous therapy of fluocinolone acetonide for up to 3 years. I think it's a great option because after one injection, the medicine lasts for up to 3 years, and they're getting this treatment on a day-to-day basis even when they're not in my office.
Indication: ILUVIEN, fluocinolone acetonide intravitreal implant, 0.19 milligrams, is indicated for the treatment of diabetic macular edema, DME, in patients who have been previously treated with a course of corticosteroids and did not have a clinically significant rise in intraocular pressure. ILUVIEN is contraindicated in patients with active or suspected ocular or periocular infections, including most viral diseases of the cornea and conjunctiva, including active epithelial herpes simplex keratitis, dendritic keratitis, vaccinia, varicella, mycobacterial infections, and fungal diseases. ILUVIEN is contraindicated in patients with glaucoma who have cup-to-disc ratios of greater than 0.8. ILUVIEN is contraindicated in patients with known hypersensitivity to any components of this product. Warnings and precautions. Intravitreal injections, including those with ILUVIEN, have been associated with endophthalmitis, eye inflammation, increased intraocular pressure, and retinal detachments. Patients should be monitored following the intravitreal injection. Use of corticosteroids, including ILUVIEN, may produce posterior subcapsular cataracts, increased intraocular pressure, and glaucoma. Use of corticosteroids may enhance the establishment of secondary ocular infections due to bacteria, fungi, or viruses. Corticosteroids are not recommended to be used in patients with a history of ocular herpes simplex because of the potential for reactivation of the viral infection. Patients in whom the posterior capsule of the lens is absent or has a tear are at risk of implant migration into the anterior chamber. Adverse reactions. In controlled studies, the most common adverse reactions reported were cataract development, ILUVIEN 82%, sham 50%, and intraocular pressure elevation of greater than or equal to 10 millimeters of mercury, ILUVIEN 34%, sham 10%.